So I just want to welcome everybody to the Converging Approach to Sustainable Resilience, TIDES 2020 virtual demo, which is scheduled for October 20th to 21st, 2020. This is for a breakout session on nutrition, public health, and integrated cooking. For this session, again, our discussion is going to focus on building sustainable healthcare systems in low-income settings, and our discussion panelists include experienced team of researchers and practitioners, Dr. Amira Roess, Dr. Mona Sarfaty, and Dr. Michael Van Frieken. He's not here yet, but I hope that he can join us as we move along. So just to quickly introduce the panelists, just a sentence or two in the interest of time. Dr. Roess is a professor of global health and epidemiology at George Mason University. She's an epidemiologist with expertise in infectious diseases epidemiology, multidisciplinary and multi-species field research, and evaluating interventions to reduce transmission and impact of infectious diseases. She currently oversees several longitudinal studies to understand emergence and transmission of zoonotic infections diseases globally, including emergence and transmission of Campylobacter, the Middle East respiratory syndrome, and the development of the microbiome during the first year of life. Her research has had impact in multiple countries, including the US and in global settings. She holds a PhD in global disease epidemiology and control from Johns Hopkins University. Welcome, Dr. Roess. And Dr. Mona Sarfaty is the director of the program on climate and health in the Center for Climate Change Communication at George Mason University. The program collaborates with the medical societies and research organizations to increase awareness, research, and preventive activity regarding the health effects of climate change. As a family medicine professor and physician for over 30 years, Dr. Sarfaty has engaged in research and teaching focused on primary care, cancer screening, and public policy, including the health effects of climate change. Dr. Sarfaty is the author of widely circulated guides and articles on how to increase cancer screening rates in practice and on improving practice outcomes by using the features of the patient-centered medical home. And a little bit on Dr. Michael. Dr. Michael Van Frieken is an assistant professor of epidemiology at George Mason University. His research interests include vector-borne disease surveillance, control, and pathogen discovery. He has ongoing projects in multiple countries, including Kenya, Mongolia, and Haiti. His work has had direct impact on guiding treatment policies in Mongolia and management of malaria in Haiti. He received his PhD from the University of Florida and completed his postdoctoral fellowship with Duke University Division of Infectious Diseases. So welcome and thank you so much for joining us. So to start us off, in the interest of time, I will ask my first question, and please feel free to answer it with, focusing maybe could focus specifically on your area of expertise, or feel free to expand it as much as you want. So my first question to lead us off is, what are your perspectives on what a sustainable global healthcare system entails across different settings? So Dr. Amira, do you wanna take that on first?
Yeah, sure. I think it's important to recognize or acknowledge the work that's been done by some of the World Health Organization working groups around this, and the work that they have done to put together what they call the building blocks. Those are a very important document for those who are interested in healthcare system strengthening to go to for more information about what are the components of a health system, and what are some of the things that we're looking for when we're talking about sustainability. So healthcare systems include the people at the center, the community that we're serving, and there's lots of blocks that feed into the delivery of healthcare. You have government and policies and funding that are all really critical for health systems to be functional and sustainable. And you have the healthcare workforce, you know, who is going to be implementing the different programs and who's going to be delivering the healthcare. And there are a few other really important building blocks to consider along, you know, the healthcare infrastructure, the physical buildings and the different resources, the IT resources, especially as we are increasingly in an era where we're trying to move around a lot of data to make healthcare delivery more timely and responsive to what people actually need. So those are some of the things that we have to consider when we're thinking about sustainability.
Thank you. Dr. Sarfaty, is there anything you'd like to add, especially for you who works here in the US and also thinking about climate issues?
Yeah, definitely. Thank you. Our group, which is called the Medical Society Consortium on Climate and Health, brings together doctors and other health professionals to inform the public and policymakers about the health harms associated with climate change and the health benefits associated with climate solutions. And so when I think about sustainable healthcare systems, I think about, especially about the vulnerabilities that healthcare systems have because of climate change. And of course, those vulnerabilities depend greatly on where the health system is located. And so one area that may be facing torrential rains and the danger of flooding and all of the potential disruptions that go along with flooding will be the vulnerability for that area. Another area which is facing extreme heat and very high temperatures and danger of a lot of people to be affected by heat illness will have other kinds of vulnerability to their staff and to the people who will be turning to that health system for care when they need it. And then, of course, you know, we have places that are more vulnerable to storms and to the insect-borne or tick-borne, mosquito and tick-borne infections and so on. And so if a particular health system is in a place where they're likely to lose electricity in the face of a storm, that's a huge vulnerability. And in order to sustain that health system, it must be possible to figure out how to provide electricity, even in the eventuality of an extreme event like a storm or other kinds of, or just, you know, hurricanes, torrential rains, etc. So power needs, the physical building and making sure that that building is as protected as possible from whatever climate change may cause in the area. These are all things that every health system really needs to think about and evaluate. And the World Health Organization has tried to produce a report for every country in the world that looks at the specific vulnerabilities and at the things that communities need to do to protect themselves from those particular climate threats. Now, of course, in a large country like the United States or China or Russia or Australia, there will be different kinds of climate-related threats depending upon where in the country that health system is located. So sustainability really means compensating for the threats that climate change is going to bring. And then, of course, that also means being aware of the resources that would be needed to continue to operate the health system. And that could be, you know, foodstuffs, the availability of medicines or intravenous fluids or other, food that must be available for patients who come to that health system or for the people who work in that health system. So I would say there are really a wide spectrum of considerations that go into what makes a sustainable health system. And that's all in the relatively short run, within a week or a month or a year. When we're talking longer term, obviously there are a lot of other concerns that we need to address that makes for a sustainable system. Does it have the funding that it needs? Does it have the personnel that it needs, the doctors and nurses and the other people who work in the health system? Do people in the area have a way to get to the health center or system, and so on? So there are a lot of considerations, and there's a lot to talk about.
Thank you. As you were, responding to these questions, and I realize how important it is to think about sustainability really right from the beginning. And if you are building something, whether it's a house or thinking about a healthcare delivery, that you want to start at the beginning. But unfortunately, for the most part, you find that sustainability usually tends to be an afterthought, or something that we only pay attention to when, for example, there is an emergency and we stop to think, oh, what should we do? How do you approach this discussion and talk and policy and practice around sustainability for healthcare systems? How do you make this happen?
Well, so if I can take a crack at that question, I think it's very important to bring multiple people to the conversation, first of all. So depending upon the role that different people play in that system, they'll have a different perspective on what needs to happen to make it sustainable. So it's very important that these conversations include everybody who works in the system and the community that depends upon the system, so that there are multiple perspectives that, that inform our understanding of what's really required to make the system sustainable. And some of the research that's been done on resilience shows that just the act of bringing people together to have these kinds of conversations, whether it's inside the health system or outside the health system and the surrounding community, just the act of bringing people together to have the conversations often means that a system will be more resilient. And so there's a little bit of magic there that, by virtue of having people who are involved confer, that things happen in a way that is beneficial to the system.
Thank you. Dr. Roess, I'm interested in the work that you've done globally, and you continue to work with different communities in various research projects. How successful have you been in really getting people, all these different parts, to the table in discussing how to move forward with building these sustainable systems of care?
Yeah, so what I found often helps is to tackle the issue using multiple approaches. So, on the one hand, when I've had the opportunity to work with communities, right, at the community level, you could see a lot of immediate success by having ownership, community level ownership of the healthcare system or healthcare delivery or intervention. And it's always helpful to build off of whatever the existing infrastructure is, or most of the time it's helpful to do that, especially when you often find that there are credible healthcare sources at the community level that only the community knows about. So that's a really important piece, I think, of building something sustainable. And simultaneously, when you have time and resources, it's always a good idea to also work with the central offices or the the ministries of health in the capital. And it's a massive effort, and it takes lots of different partners to work together to really build something that's long-term and sustainable. And the experiences that I've had, a lot of times it was sort of by chance. I happened to be working on usually an infectious diseases issue, whether it was an outbreak or a research project, and the local PIs or the collaborators were saying, what we really need to do is build something sustainable and make sure that we have a sustainable surveillance system that is helping the local community really understand what's going on, so that they can make sure they have the resources they need, and they can talk to the ministry at the Capitol. And so I've had lots of great opportunities to sort of observe where the breakdowns are and what the obstacles to having sustainable health systems or healthcare delivery can be. And so really, I think for something to be truly sustainable, you have to have community ownership, and you have to collaborate with the ministry, because oftentimes they're the ones that are holding the long-term resources that are needed to keep things running throughout the country and in the area where the healthcare is needed.
Have you seen any differences when you think about the governments? Are there certain governments or certain parts, regions in the world that are more responsive to building such systems, and other areas where you see more difficulty, or what has the experience been?
So, a lot of times it seems that the interest gets tied to resources, right? So if a Ministry of Finance sees that malaria is a really important problem right now, then they tend to allocate funding for malaria interventions, malaria healthcare, malaria service delivery, drug distribution, et cetera. And so, that's sort of the reality of what you see happening. And there's lots of, case studies that have been written up to, really kind of unpack what we've learned over time and what lessons we can apply to making more or building more sustainable healthcare systems. Yeah.
I think a big tension, a potential source of tension is to what extent a country has central planning of its health system versus a health system which grows up in separate pieces in different places. And the United States is definitely an example of the latter, with a lot of different systems growing up in a lot of different places, although it does have some central component in that one of the biggest payers for healthcare in the United States is the government through the Medicare program, which provides healthcare for senior citizens. And if, people often complain about just how different your experience of healthcare can be in the United States, depending upon where you are and what health system you end up in. That's the US version of the system, whereas you might think of some other countries like the United Kingdom, where they've got the National Health Service and they have a more sort of agreed upon model that everybody follows, as almost like a franchise model, where pretty much wherever you are, how the system is going to operate, and you get a pretty similar treatment in a pretty similar way. And I would contrast that with, a system where you've just got all these kind of private restaurants and everybody does their thing. And yes, you get a meal anywhere or everywhere, but there's just a lot of differences in how they do things. And so that's one interesting thing to think about. And, what is the the relative benefit of going each of those different ways. I think the United States obviously has a lot of problems with the health system. We don't get as much out of our health system. Our age, our longevity is not as good as most other developed countries in the world. And that's because many of the people who live in the United States are not getting the same level of healthcare or getting any healthcare. In most of the other developed countries, there's a system that makes sure that everybody gets some healthcare. And so that's one of the benefits of having a centralized system. Everybody is going to get some of the same treatment. So anyway, that's another thing to think about.
Some of the things that you've mentioned, thank you. Some of the things that you've mentioned, and before I go forward, actually I forgot to mention this. In case, for those who are in attendance, if you have any questions, feel free to write them in the chat, and then we'll answer that. We'll present them to the panelists as soon as we are done with the discussion, and then they can respond to them. So please feel free to do that. But going back to my question, as you were talking, there is the issue, importance of resources, funding, management, partnerships that are critical to make this happen. What is, and you maybe you've already touched on some of these, the type of system that is running, but what do you think is the secret? I don't know whether there is one, but what is the secret to having sustainable funding and management, in low-income areas, low-income countries? What is the secret to having sustainable funding and management, but also sustainable partnerships that are actually working for everybody? Dr. Roess, would you mind taking that? Okay, go ahead.
It's right now, when we're dealing with COVID and all of the health emergencies that we're seeing across the world, it's sort of putting a different lens on what's going on with healthcare systems and access to healthcare. So, in some countries, you're seeing that there's a tradition of or a culture around providing more uniform access to healthcare, and some of that is tied, to what funds are available and what the ministers at the top have allocated or have decided to allocate to the different regions, sometimes based on per capita. Or some attempt at a fair rationale for how they're going to distribute funding. So sometimes you see, these systems that seem to be pretty even, and you find that in some countries there's better access to healthcare, like Senegal versus DRC, let's say, but a lot of that is tied to other really big factors along the country's stability at the moment and their history, right? And their resources, so Senegal and DRC, yes, they're both technically low middle income countries, but they're still, very different, even within that category, right? You have one that's really lower, towards the end of the low income category, and one that's a little bit higher, but still considered in the low income category. So, I don't think you can really ever downplay how important, GDP is, and, the economic reality of a country is in the healthcare quality, especially in low and middle income country. And then, like I mentioned, the culture around it and what the ministers have decided is a priority or not. There's, you see also in like Jordan, right? That's also technically a low income country, and sometimes it goes up to middle income and then it goes back to low income. and they have a monarchy, and the monarchy has decided, that they're going to provide pretty even healthcare access with a pretty good level of quality for the region, for all of their citizens, and a lot of that is also tied to the resources available, and then the size of the country, right? That's also going to make a difference. So those are some of the things that I sort of see as being kind of predictors of which countries are going to have more sustainable, more even, and higher quality healthcare availability.
I don't know whether Dr. Sarfaty is still with us, but in case, thank you.
Mm-hmm.
Dr. Sarfaty, are you still there? No, I don't think so. Okay, I have maybe just two more questions, and then I'll open it up for questions from the students and from the attendees. You mentioned the COVID-19 has happened. Now we have to open our eyes and really think through, okay, what next? What do we learn from this? What has worked, what has not worked as well, and how do we bounce forward in building hopefully better systems? And then the other question, do you see an interest in building something different in the countries that you have some experience with or you have knowledge of?
Yeah, so with COVID, what you're finding is the countries that had more active surveillance, more active public health systems that were more preventative, they're doing a better job, right? So not 100%, but for the most part. So Canada comes to mind. I'm going to go back to Jordan because I know a lot about Jordan. They've been doing a really good job with how they're controlling this. And part of it is that they're building on their existing infrastructure, right? The Mona had mentioned how in the US we have sort of a less uniform system here. And what you find in the US is we never had, or in the last few decades, we didn't really have a uniform healthcare system, a uniform public health system, a uniform surveillance system. And so what we're seeing in this chaotic response to COVID here is sort of the result of having this somewhat, fragmented system.
Mm-hmm.
The arguments are, well, the US is larger and more diverse than other countries. Well, yeah, maybe, but Canada is also pretty diverse. And so I think the lessons are that if you have a pretty good foundation for your healthcare system and your public health system, your response is stronger and better to these shocks, to these emergencies. There's lots of proponents for the UK system, and there's lots of people who, really are critical of it. And what you saw in the UK is sort of another example of some, problems in the implementation and in the delivery of communication and messages, and a failure of leadership in a lot of ways, right? That's what we saw in the US. In a lot of low-income countries, that I'm familiar with, you have, you have some health infrastructure that's been built around certain emergencies and diseases, and that's been the infrastructure that they're building upon for COVID response. So, in Bangladesh where I work, it's in a real crisis, but some of the more successful programs around COVID testing have had to build on some of their child survival interventions and public health systems around child survival, where they had systems in some parts of the country that were really focused on delivering interventions to improve child survival. And so they're using those same systems to deliver messages about COVID, to deliver tests and things like that. So I think those are some of the main themes that we're seeing out of this. And of course, you have to keep in mind that this is somewhat of a simplistic, very fast overview of what we see happening in healthcare system delivery in the time of a crisis, in the time of this pandemic. But I still think there are some lessons that you can learn or some themes that are emerging.
Okay, thank you. Do you think, now that I know it's pretty early on, but now with people's experiences with COVID-19, do you see any chance of US maybe rethinking and figuring out what to do something differently? And what would you recommend?
So, it's always nice to think that we could learn from this and we can, move forward and have something better. But I have to be very realistic and highlight that one of the things that we learned in our studies of infectious disease history in the US was that you've never been good at having cohesive messages, especially around public health. And if you just look at the 1918 pandemic, you see the same behaviors, the same failures of public health messages replaying themselves 100 years later. And, for a long time when we would teach about the great influenza, the big pandemic, we would hypothesize about why was there such a large percentage of people who got sick and died, right? It was a very large percentage of the world's population and the US's population that was affected by the 1918 flu. And the hypotheses were always, well, it's likely that we didn't have the same level of healthcare and healthcare access, the same great hospitals that we have now. We didn't have antibiotics back then to take care of secondary infections, and that possibly the majority of people died from pneumonia that could have been treated with antibiotics, right? Well, that's how we taught the 1918 influenza. And I think we're going to be teaching it a little bit differently now, because now we're reading through the old newspapers and the old newsletters and old letters that people wrote to each other. And what's very clear is that there was a lot of confusion and dissent around whether or not people should wear masks and social distance, right? Two very simple interventions. And you would have, stories of the governor saying, social distance and wear a mask, and the sheriff saying, no, you don't have to, I'm not going to enforce it, right? And it's the same thing that's happening again. And I don't think we will, we haven't learned in the last 100 years. I don't know if we're going to learn in the next 50 years and the next 10 years. Maybe we'll remember something for the next 5 years, but, are we going to behave differently when the next pandemic hits? I don't know. I would like to think that our public health system will get an infusion of support, but the reality is public health systems are always at the mercy of this paradox that if you do everything well, you don't have people dying of infectious diseases, you don't have people getting sick from contaminated water, things are quiet. And then the policymakers take funding away, right, from the public health system. And then you have this public health system that slowly starts to break down over time. And that's what's happened here and in lots of parts of the world, right? People in the US, they don't want to pay for active public health surveillance. And the policymakers, will remove funding from there very quietly and put it somewhere else. And so, I just don't know if we're ever going to really invest in a long-term sustainable public health system or even healthcare system in the US.
There's need for political will.
Definitely, there is. There's a very strong need for political will. And I think the conversation at all levels of society and all age groups has to change a bit and has to incorporate this idea of public health infrastructure. We talk a lot about how we need more STEM, and we do. We need STEM, and we need the idea of engineering and mathematics and arts to really produce a thinking populace who can, critically analyze what's going on so that we avoid the situation that we're in right now that's become highly politicized, without any understanding that a virus is a virus. It doesn't care if you're red, blue, or orange, right? It doesn't. So I think there's a lot of interventions that need to be happen at every level of society to save us from the next pandemic.
Your sentiments, actually, the point you've just made echoes an article that I think was it yesterday or the other day? I think it was I don't think it was in the New York Times, but it was in one of these newspapers that clearly was talking about, this is not just about the virus and the biology and understanding that, but this is a bigger conversation for the US, that we have to understand why are some sectors of the population affected more than others? Why are we refusing to come together to see how we can protect each other and be able to come out of this without too much damage and misery? It is bigger than just the biological science of it. And they're really hoping that people do not forget to start figuring out what is really going on with the US population around such matters that seem so simple, but yet they are not. Yeah.
Right. We have our work cut out for us, for sure.
Thank you so much, Dr. Amira. This is very interesting and can be very engaging conversation and discussion. So I'm really glad you're able to join us. And I'm now seeing some questions coming up in the chat. So I'll just start from the very top. There is a question from Tim Barnes. When you guys, I'm assuming everybody working in the healthcare system, attempt to obtain sustainability in other countries you work with, does this factor in those countries being self-sustainable, or does this sustainability depend on unending help from others?
Right, and that's where, I had mentioned that it's better to work within the community that you're in and to build off of what's already existing. And, there are lots of roadmaps out there for how to move from something that's donor driven, right, to country driven. And that's really critical, because what you're seeing happen a lot of times is that donors come in and they say, now we will focus on child health, or now we will focus on Ebola or HIV or what have you. And so, the dollars are tied to successes and processes tied to those priorities. And that's always a problem, because by definition, it's not flexible, and it doesn't allow the country to make their own decisions. So, there's been a massive amount of work in this area. You can do a dissertation on 1% of what's been done in this area, so that's just to sort of highlight that we're just kind of doing an overview, a cursory look at what's at this topic. So yeah, there's a lot of talk about how do we move from the donor-driven agenda to the country-driven agenda, and then how do we transition from this kind of reliance on foreign aid to some other kind of reliance, tying it to the local economy somehow. So, there is a lot of examples on how to do this as well.
And I want to believe that if you're thinking about tying to the local economy, that the local economy has to be a thriving economy up to some extent. And so this might be going back to, well, how do we build these economies to be able to sustain those health systems? So it is bigger. It's much larger than just donor aid versus not providing that.
Right, because you have to take into account trade and a lot of other things that, we don't have time to get into here, but it's much more complex. Yes.
Thank you. Our second question is from Grace Christophic. Are central planned healthcare systems better than systems that are developed on their own? And Grace, I'm not so sure what you mean by develop on their own. Do you want to maybe expand a little bit on that? Grace?
And
all right, but do you think you can answer that if you get the question, what she meant by that?
So, there is again, a whole body of research that kind of talks about the pros and cons of both this centrally planned healthcare system versus healthcare systems that are not regulated by the government. And there's some schools of thought about how the two have to be brought together, because sometimes the unregulated healthcare system that reaches populations that are not going to go into a regulated healthcare system. And so there is a lot of talk about how do you get the best out of both of these and merge them together to have the maximum reach that you can. And there's a whole literature about acknowledging the perceived and the real value of indigenous healthcare systems and traditional medicine here in the US, in other countries, right? And then how do we integrate that with the this new pharmaceutical-based healthcare system, right? So there's lots of layers to this, and I think you guys are asking some really great questions, and there's so much that you could read on this that would really help you understand this issue.
Is there any example that you could share with us, or a country or a place that has merged and seen some success with merging two systems like this?
I think there have been some examples of smaller case studies where people have tried to work with the unregulated drug sellers. That is an important source of healthcare in lots of places. Mm-hmm. And there's examples of countries that have tried to shut down that sector. Then there's examples of countries that have tried to work with that sector and regulate them or work with them to reach populations that they don't typically reach. Mm-hmm. And so you can see that there are pros and cons to each of these different methods. If the goal is reaching more people and providing more healthcare, then you don't want to drive the unregulated sectors, healthcare sectors, underground. You want to lift them up, make sure that it's visible what they're doing, and add some level of proper regulation to protect the health of the people. Much easier said than done.
Thank you. All right. A question from Manisha. What could be possible reasons for US following small and different healthcare systems over a central planned healthcare system?
You know what? There's a couple of really good theories about what happened. I mean, first, look at how the US came to be, right? Different states joined the union, and we've retained this idea of states as being somewhat independent. And that's part of our culture, and that's part of how we look at everything, including healthcare delivery. So that is sort of at the core of why we are where we are.
Yeah. All right, thank you. Yuchuan has a question. I know CDC updated the knowledge about how to prevent COVID, but I still saw some news saying that COVID is not a big problem and some people don't wear masks in public. How do you think healthcare providers can do? How do they let people realize COVID is a serious problem and that we should try our best to prevent it?
Right. So I think COVID is highlighting some of the problems that we have in our country that go back to this, to our culture, our lack of having a robust, uniform public health infrastructure and healthcare infrastructure, and our lack of having like a strong central voice, especially for this pandemic. The messages from the top have been so confusing for most people that people are just sort of picking and choosing who they're going to go to for their source of information. And that's at the core of why we're in the situation where a lot of people are saying, I don't perceive this as a big deal, right? So I think that we need to have a strong, trusted leader who we can go to, because again, remember, that's part of what people do. We are looking for an authority. We look for an authority figure. And in an emergency, we look for that more. Otherwise, the messages are confusing and muddled, and we have the situation that we're seeing now. So I think the healthcare infrastructure establishment is really trying to come up with unified messages around what the right thing to do is in terms of wearing masks. And you see that in some of the messages that are being put forth by the American Medical Association. On the global level, you have the World Health Organization trying to come up with uniform messages, and it's very challenging. And we have to acknowledge that this is an emergency setting, and a pandemic is always going to breed some level of confusion and chaos because of the nature of the pandemic and the emergency around it. And that's the way it's always been in history. And we now are faced with trying to move forward, learn from our very recent mistakes this year, and do better tomorrow and next month, etc.
If somebody who has no knowledge of public health, not in that area, comes to you and says, Dr. Roess, who should I listen to with regards to the COVID prevention and staying healthy and keeping my family healthy? Let's say even here in Fairfax, what would you say?
The best source of information right now is going to be your local health department. And the reason I say that is they're going to know the local situation and the drivers of infection in your area, and they'll also know the local culture. So they should have the best messages that are tailored for the local jurisdiction. And in the US, we're seeing that there are very different epidemiological profiles of COVID in New York City versus Washington State, right? And so it is not a one-size-fits-all approach. And part of what's happened is because we were lacking that central message and we didn't have a national, face mask mandate and things like that, we really have to be we just have to acknowledge that now is the time to really look at your local leaders for the best, most timely guidance that you can get. And I have to go to another talk that I'm giving about Mason Votes 2020. If any of you are interested, we'll be talking about how COVID-19 has changed the vote this year.
Is that talk today?
Right now.
Okay. I want to thank you so much, Dr. Amira, for taking the time. This is really interesting. It's really intriguing discussion. I wish we had more time, but I'm hoping you can join us on Tuesday. And for everybody else in attendance, thank you so much for your questions and for being with us. I look forward to seeing you at the TIDES event itself on Tuesday, starting on Tuesday and ending on Wednesday. Thank you so much. Have a good evening.
You too. Bye. Bye, everyone.
Bye. Okay.